chairperson for the first session, Dr. Ramiz Al Swailem, consultant rheumatologist, and he was the past president of the Saudi Society for Rheumatology. He got a lot of effort for the Rheumatology Society, and he is actually the creative of the society, which was in 2010. The second chairperson is Dr. Khalid Al-Naqbi. Dr. Khalid Al-Naqbi, he's the vice president of Emirate Society, and he is the head section of rheumatology department in Al Ain Hospital from Emirate. Thanks for both of you, and we'll start the session.
طيب بسم الله الرحمن الرحيم الحمد لله والصلاة والسلام على رسول الله. Thanks to Dr. Hanan for bringing up this Saudi Society for Rheumatology again. Thanks Dr. Ramiz, Dr. Khalid for the introduction. So the objectives of my talk today is to illustrate the current published knowledge about rheumatoid arthritis in Saudi Arabia. I want also to review our single center experience in registering RA patients. And I'd like to question with you or challenge you with the need to develop our Saudi recommendation for management guidelines for rheumatoid arthritis. So this was an article, systematic review that I've done in 2014, and I will mention a few things from that review, and I will also update the published data from our colleagues. So I apologize if I didn't mention your participation in research, and just remind me at the end of the talk if I did miss something that you have done. Just a quick thanks to Saudi Saudi Medical Journal. I'm not sure if you can see this. Most of the articles published from Saudi Arabia about rheumatoid arthritis in Saudi Arabia were in the Saudi Medical Journal. Unfortunately, Annals of Saudi Medicine, which is another major journal in our country, did not publish any article. King Abdulaziz University published few. So this is thank you for Saudi Medical Journal. So the classification and types of studies that were published from our country, epidemiological and clinical features, this is the way I classified it, laboratory-based studies, radiological features, and management of RA. The common thing among all publications is single center, single author at the beginning in 1987, 1995. It used to be single center experience. Subsequently, this pattern continued, unfortunately. Single center, single authors, multiple authors from the same center. Sometimes multiple centers like study of Dr. Al-Bishri, Prof. Suzanne, Dr. Basuni. They published collaborative work. There is a questionnaire-based studies with Dr. Walid Hussein, myself, Dr. Nahid, and we used to, we like this kind of publication where we are assessing outcome measures based on questionnaire, and there were several review articles in the region. Prof. Abdul one of the, this is, I'm not sure if you can see the pointer, this study in 1998 from epidemiological, one of the, I wish if he continued to do the study of the epidemiology of RA. This study, until now, it's been cited. Prof. Al-Arfaj, Prof. Al Swailem. And again, this is, sorry, to go back, there is a publication here about, since 2006, about genetics of our RI patients. They are B104, they are B108 and 10. Dr. Hussein recently published with a group of colleagues also the kind of same findings, and they discovered 2 new alleles in Arabs with rheumatoid arthritis. This is a study that we have done in 5 different cities with different colleagues, Dr. Matuga, Dr. Walid Hussein, and Dr. Al-Asiri from, and we've identified the delay that we are having in diagnosing rheumatoid arthritis up to 36 months. This is way beyond the international limits, which is up to 1 year delay in diagnosing rheumatoid arthritis. And this is a study by Dr. Al-Umair. He talked about it in more than one occasion, where we studied the patterns of practicing rheumatologists in the kingdom. How do they practice and how do they deal with RA patients? And again, this is the clinical features of RA, different studies. And I like Dr. Prof. Attar, Suzanne Attar publication when she studied the extra-articular manifestation, and the most common one was anemia. And also, Prof. Attar continued to publish several kind of study from their cohort of patients in King Abdulaziz University about the bronchiectasis, symptomatic bronchiectasis, the pleuropulmonary manifestation, hyperlipidemia, and depression, published in Kuwait Medical Journal in rheumatoid arthritis. Two radiological studies of interest. They compared, colleagues compared the findings between RA in Saudi Arabia compared to the West, and west of Saudi Arabia compared to the East. Interesting findings. And also the laboratory studies, credit to Dr. Al-Janadi, one of the pioneer rheumatologists in the kingdom. Since 1993, he kept publishing about laboratory-based studies in RA. Dr. Hanan also, she did work, Dr. Hanan Reyes in 2011. Dr. Attar also published about vitamin D11 in rheumatoid arthritis. This study, again, Dr. Hanan, about the management study, Dr. Suzanne published an article about the gastrointestinal side effects with methotrexate. And since that time also, since 2014, a group from Eastern Province published about the safety, efficacy and safety in their center about patients with refractory rheumatoid arthritis. Dr. Sultan Abdulaziz, is she here, published about from King Fahd Hospital, her long experience over years about the use of biologics, and she compared in her center the efficacy and the remission rates of different biologics in RA patients. And again, Dr. Suzanne, Prof. Suzanne, mashallah, very active for rheumatoid. She published the infection rate among the users of biologics in her center. You can see the pattern is continued, single center, multiple authors, and this is what we really need as a conclusion from my talk is collaboration. We have extensive experience in our country with the use of biologics. I published this a few years ago from a specialist hospital where we use biologics in patients with hepatitis B, C, and HIV. We published a group with our colleagues, led by Dr. Sultan Abdulaziz. Dr. Al-Umair was with us, and about the use of biologics in patients with hepatitis B and C. So our experience, local experience with the use of biologics are extensive. We are not naive in terms of using biologics or in managing RA patients. And keep this in mind. At the end, I'll tell you why did I mention that. This is an interest that we've been developing and publishing for years right now, workability. I'm really interested in the workability outcome in patients with rheumatoid arthritis. This is a study that we published a few years ago. I wrote an editorial, treat to work instead of treat to target, as something of great importance to the patients. Patient-reported outcomes are making sense for our patients, may not make sense to us, but this is what they are really care about. Did not take much of international attention because we are in Saudi Arabia, not in Europe. We published again about workability with the use of biologics and fatigue. But until now, we don't have stringent data registry for rheumatoid arthritis in Saudi Arabia, and there is something missing in this regard. There is effort by Dr. Sultana, for example, but again, this is a kind of cohort of study, local one center experience and the group from Eastern Province. But as we all know, the importance of registries, it is a collection of data as a definition regarding patients who are generally followed in a prospective manner. So it has to have a structure and a target and a goal. There are registries based on diseases. There are registries based on treatment. As you all know, current guidelines are mainly based on registries. And I quote this interesting finding, it may not sound scientific. 15% of the knowledge is coming from randomized controlled trials, but actually 85% of knowledge is coming from observational studies. Registries is a classical example for that. So we need registries to guide our strategic planning for rheumatoid arthritis in our country. So this is the effort that we've been working on for years now in Al-Zadi Chair of Research in Rheumatic Diseases, and we did apply it. We did include up to, I'll mention a few findings here for you. And thanks for the advertisement that we had from the scientific committee. They want us to publish it, to present it as an oral, then as a poster, that's fine. And we don't want to change the name. It is going to be Rheumatoid Arthritis Study Database. So these are the basic information. What we sort of data we are collecting, it's extensive. We don't focus on treatment. We do focus on the comprehensiveness of the data collected from patients. And DAS28 is the target outcome measure that we are using, in addition to workability, in addition to HAC. So this is just to show you how extensive we are. And we have a dedicated person to enter the data in our center in Faqih Hospital. And this is the data that we are going to publish soon. It is in abstract. You can see it in the poster session. We have 575 patients. First symptoms suggesting RA were joint pain in 50%. Duration of between the first symptoms, the first consultation, majority were 3 months. This is an early arthritis, may not represent our society because we are a tertiary care center, private center. We do have quick access to care compared to governmental hospitals and other sectors. So most of the patients are actually being evaluated by orthopedic surgeon. They have, in that study published in 2016, up to 70% of the patients will be seeing orthopedic surgeon first, and then they will be seen by rheumatologist. In our cohort, up to 50%. So no major differences. Still a major problem in our societies. Patients tend to believe that joint symptoms are dealt with by orthopedic surgeon, not by rheumatologist. And again, we have a shorter duration of symptoms. And this, again, I don't think it's representing the society because we are a private hospital, though it's a tertiary care center. And the rheumatologists are the most common one who are making the diagnosis for RA. Aqua positivity, it's not something different from what's reported in the literature. We have up to 50% positive, both are rheumatoid factor and aqua. Most of the patients are middle-age groups from 40 to 60 years. The DMARDs that we're using, single-use or combination, 30% of our patients are on biological or anti-TNF or non-anti-TNF biologics. The most common morbidities here in this cohort is osteoporosis. I know most of the reported comorbidity in the world is hypertension, not osteoporosis, but I guess in our cohort, because of use of steroid, or we didn't actually know exactly why this is in our cohort. It's probably from steroid. And this is the most common drug that we are using. Sorry, I'm not sure if you can see in the pointer, is Zalgen, tofacitinib. And then followed by adalimumab, and then followed by etanercept, and then tocilizumab, and then rituximab, and certolizumab. We are using it mainly for RA pregnant patients. None of our patients are taking infliximab anymore. So this is quite exciting and interesting. Remission rate in our cohort is up to 46.6% of patients, low disease activity 35%, collectively up to 80% of our patients are in low disease activity or remission. Still, we have 5.733 patients who are having high disease activity, and we are working we have another project to study these kind of patients, why they are not responding. HAQ score, up to 50% of our patients are having really impressive HAQ score. So just quick comparison. This is not a presentation for the details of our registry, but comparing our findings to recently published meta-analysis last year, end of last year, the 17.2, 16.3, 21.5, 23.5, all these are reported pooled remission rates and from different registries. Ours are not, I don't think it's different from the rest of the world. There is, however, as we all know, significant heterogeneity. It depends on the quality of patients, genetics background, and the onset of diseases from the time of diagnosis. And obviously, there are some registries with really excellent and impressive remission rate. It's good to know how are we doing in comparison to the rest of the world, and definitely we need to study our patients in depth in order to direct our strategic planning for our patients and for our country. And just quickly, we had another project to study what outcome that would predict workability from all different parameters, including ultrasound findings that we are using heavily in our clinics. And the thing that we found that this is the study that is going to be published soon from our registry. I don't want to bother you a lot, but obviously, workability is disturbed in patients who did not achieve remission or did not achieve what we want to achieve in as the remission or disease activity. But the impressive findings that HAQ score and fatigue were the most predictive factors for workability in RA patients. It's not musculoskeletal ultrasound score. It's not DAS28. It is, again and again, this is emphasizing the points of patients-reported outcomes, workability, quality of life is the thing that is matter to our patients, not DAS or other parameters that would have influence by the managing rheumatologist. So another point, when I published this article, someone sent a comment stating, why did you mention that you need to have a recommendation for management guidelines in Saudi Arabia? You just follow what EULAR and ACR is saying. Do you really need a recommendation for management guidelines in Saudi Arabia? So my response was, there is methodological limitations. I don't want to go into details. There's a published article about that, something called GRADE. And the access to biologics in our countries, in our country in particular, Saudi Arabia, is not similar to other countries. So why should we put all the eggs in one basket? The other point, the guidelines did not add or addresses the uses of biologics in LRA in a very vague way. It's not something that was clear to practicing rheumatologists. So, and there is concepts in literature like remission induction treatment by biological therapies, then going to drug-free period. This wasn't studied heavily in the world. I think Saudi Arabia is the ideal place where we can apply this method, this approach. Why? I'll mention to you why. And this is what I told you about the limitation in the designing of guidelines. And this is a study by Dr. Hussein Halabi, is he here? Dr. Halabi with colleagues from different Arabic countries showing that Saudi Arabia have the highest access to biological therapies in comparison to United Arab Emirates, Qatar, Lebanon, and Jordan. Saudi Arabia has the highest uses of methotrexate comparison to other countries. So we are different. Saudi Arabia is different. So we deserve to have our own guidelines, our own work. There are some colleagues who worked on Eastern Mediterranean, I don't know, recommendations, but I'm not sure if this is even applicable to us. Dr. Basil Zurkani, he's invited in this conference. He wrote clearly, we need to develop our local recommendation guidelines in every city. Until then, we can use EULAR or whatever. But I will show you this. Indian Rheumatology Association have their own guidelines. Australian have their own guidelines. South African have their own guidelines. Canadian have why didn't they just follow the Americans? Canadian, they have their own guidelines. Scottish, they have own guidelines. Korean, they have own guidelines. Japanese, they have own guidelines. I couldn't get the articles in Japanese. Turkish, they have own guidelines. British, why didn't just they follow the EULAR? They have their own guidelines. And so, this is my conclusion, ladies and gentlemen, Chairman, Dr. Hanan. We need more collaboration in research in our country. We need to stop this pattern of publishing from single centers, or I hope there is no more single authors, but we need to collaborate. I think this is the rule of the Jamia Saudiya or ourselves, like Al-Zadi chair, to disseminate the interests of research among different groups and remove our differences, our always controversial points, and just get things done for the sake of our patients in our country. We need a data registry in our country. We are now working on the online version of our registry, and we are inviting King Abdulaziz University, colleagues, and some other military hospitals in the region, in the Western region, to join us and to improve the number of our patients, and definitely work in progress to identify more and study in depth the details of different parameters that we are using in our registry. One center has 600 patients in 4 years. So imagine one city like Jeddah, how many patients will be having by the end of the year? So you do the math. We need to know more about RA in our patients, the response rates, drug survival, mono and combination therapy, switching therapies, safety. In our cohort, we do not have any single case of TB in these 600 patients, no single case of TB. We need to consider patients' reported outcomes like workability. I think, I know this is not something preferred by our colleagues in the West, but something of interest to our patients. We did demonstrate in the past that housewives are really bothered by RA as much as those who are working full-time. We need definitely to develop our own recommendation for management guidelines for RA in our country that should meet should meet our needs and address our patients' interests and benefit. Thank you very much. I'd like to thank our team in Al-Zadi Chair, Dr. Ramiz Al Swailem, Project Manager, Dr. Walid Hafiz, Scientific and Research Coordinator, Dr. Muhammad Sheikh, Training Coordinator, and Samira Nazlawi as an Administrative Leader. Thank you very much.